Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest. Brian, how are you?
Hey, doing great. How about yourself, Peter?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, today we have an episode I'm really excited about. Many surgeons today take for granted that we have available to us a wide variety of reverse shoulder arthroplasty designs. However, it was not always this way. After many failed attempts by Fenlon and Neer and others, Grammont invented the first successful modern reverse shoulder arthroplasty. And while there's been a lot of progress in design since then, understanding the history really can be illustrative here. It can be hard to see where we're going without knowing where we have been. So to discuss, we've invited two individuals that were very involved in early reverse design and have continued to be involved. So first, from Stockholm, Sweden, it's my pleasure to introduce my friend, Dr. Anders Ekelund. Anders, welcome to the podcast.
Hi, Peter. This is Anders Ekelund from Stockholm, and I've been doing this reverse arthroplasty for 30 years, and it's afternoon, and it's great to be part of this podcast.
Well, we really appreciate you coming on. And next from France, we have Didier Poncet, who's worked for several decades as a senior principal engineer for DePuy as part of Johnson & Johnson. Didier, welcome to the podcast.
Welcome. Thank you so much for your invitation. I'm Didier Poncet, part of the research and development department for the shoulder implant for more than 20 years. And I was highly involved in the reverse shoulder design with Anders Ekelund.
Okay, so before we get started here, I should mention that Didier is an employee of DePuy, which is a division of Johnson & Johnson. And both Anders and I are actually consultants and do receive intellectual property royalties from DePuy. And this podcast is actually going to be the first in a series in which we will invite members from industry to share their stories. And the podcast does not receive any financial support from industry, and it is not our intention with this series of podcasts to become like a series of advertisements for industry. Instead, we're trying to broaden our scope here and include a wider diversity of stories. So we're going to spend most of our time today discussing the Delta prosthesis, a product of DePuy that DePuy actually doesn't even make anymore. And instead, the goal is to continue our efforts to showcase all that is fascinating and intriguing about the shoulder and elbow. So I wanted to mention that kind of conflict out front. And from there, I really want to get into the beginning here. So Anders, take us back. Did you practice before Paul Grammont first released his designs? And what did it look like? What were your early solutions for kind of the cuff deficient or cuff tear arthropathy patients?
Thank you, Peter. That's a good question. I became a specialist in orthopedic surgery in 1986. And at that time, of course, we did shoulder surgery, and we had this problematic cases of cuff deficiency and rheumatoid patients would also have cuff problem. And at that time, the solution was like Charles Neer, limited gold category. So basically, they received an hemiarthroplasty in an attempt to get pain relief and limited function. And we looked into the early design reverse, and of course they didn't work. And the really game changer for me was 1994 at the CESIC meeting in Barcelona. I had particularly two cases, one young patient with anterior superior scape of a hemiarthroplasty and an elderly guy with a hemiarthroplasty with pseudoparalysis. At that meeting, Paul Grammont presented a report on 20 plus cases of cuff tear arthropathy with his Grammont type design with promising results. And I spoke to him, and that was really the change of my practice from looking into reverse and leaving the hemis in these patient categories.
It's fascinating. So Barcelona, 94, and that's when the origin story starts for you. Can you tell us a little bit about the prosthetic design prior to this point, prior to the ushering in of the traditional Grammont style prosthesis, Dr. Ekelund?
Yeah, problem with the earlier designs before the Grammont time was, of course, loosening on the glenoid side. I had revised some of them or removed them actually because of glenoid loosening. And of course, the load on the glenoid was just too high because the central rotation was away from the bone, creating an enormous force or shear forces on motion, so they couldn't hold the load. And that's why they failed. They were taking off the market. Even Charles Neer tried, and he also said the same thing. The scapula, we just cannot hold the forces, and that's why we had to go back to the simple hemiarthroplasty before Grammont came with his really great idea and concept.
Okay, so you've revised some of the early designs that have failed. You've gone to Barcelona and you've seen Grammont present kind of his first case series. And then you said you had an interaction with him. Tell us, what was Paul Grammont like? What is your personal memory of interacting with him?
We had a great discussion in Barcelona, and I showed him my two cases that were really problematic, particularly the young guy, 40 years old with an anterior superior scapula. I had tried everything. I tried the Gore-Tex tube. I tried to reconstruct the coracohumeral arch in order to stabilize the joint, but everything failed. And he said he was really a listener. He was really curious and interesting. And he said, well, it may work. I've done it mostly on cuff arthropathy, but it may work. And I said, can we do it? And I said, why don't you come to Stockholm? I will try to organize so we can get the implant to Sweden because it was not available. And it took a year. So the 2nd of June, 1995, he and his wife came to Stockholm and spent some time with me and my wife. And we had a great time together. And he was smoking like crazy. Between, in the OR, after the OR, in the coffee room, was smoking cigarette after cigarette and talking. And then he said, Anders, I think you and I will be very good friends. You know why? Because your wife and my wife had the same shoe size. My wife is very small, and his wife, and they had the shoe size 35 in European. So he said, we're going to be good friends. And we became good friends. So he came to Stockholm. Did you do a reverse together using his prosthesis then for your patient? Yeah, we revised those two cases together. And he showed me his way. He did an acromial osteotomy to access the joint from the lateral deltoid split with the part of the acromion. And then we had dinner. We had a nice discussion about shoulder and science and his development and thoughts. He was really an odd guy. He was thinking outside the box in many, many ways. And then he went back home, and then, of course, the problem started. One of the cases, the humeral component rotated 180 degrees after a week because he was press fit. So I had to revise him and cement him in a more correct rotation. And so I realized it was not without problem. But finally, both of them did quite well. And it was very encouraging.
Yeah, Anders, so just to clarify, was Grammont's prosthesis, was this really truly the first reverse total shoulder arthroplasty design on the market in Europe? And if so, maybe we can delineate some of the merits of it.
No, we had the older ones like the Kessel and so on before, but they were not. They disappeared early in the late 70s, early 80s. So at that point, we didn't have any reverse on the market until I managed to get this early design of the Delta prosthesis into Sweden in 1995. And the Shoulder Society in Sweden, my colleagues said, "Oh, this is going to stay like all the others. So why don't you do it and we'll see what happens." So that meant that, and at time and the year to follow, I was the only one trying to do it, and everyone was looking and just waiting for all the failures that did not occur. And of course, this was not the first design Paul Grammont had. He had some early design, but this was basically the first that was on the market and that we could get access to.
Okay, so you mentioned the humeral component rotated. Can you just maybe briefly review the design of the first one that you did with him? What did it look like? My memory is it's an all polyhumeral component, a Ekelund component. Does it have screws? Was it a post? What does it look like?
Yeah, there were two sizes of glenosphere, and the metaglene plate consisted of similar to the one right now, but a little thinner, and it had two screws that you could angle superior and inferiorly, and then one anterior and posterior, but they were non-locking, so they were not really locking into the plate the way they are today. And the glenosphere was attached by a thread. On the outer surface of the metaglene, there was a thread. So you took the glenosphere, which has a thread on the inside, and you screw it onto the metaglene. There was no central screw fixation. And on the humeral side, there was a press fit, hydroxyapatite coated, that consisted of an epiphyseal part and a distal part that you just connected by a thread. And the problem with this design was, first, the glenosphere on the right shoulder unscrewed. So we saw some dissociation because the thread, when they were moving the arm, finally make the glenosphere loosen. And on the humeral side, we saw some unscrewing, particularly when there was a proximal humeral bone loss in revision. The two parts came apart. It started to unscrew, and that's why we started the discussion with Medinol, the company at that time in France, that there need to be some design changes to decrease the risk of these early problems. And the third problem, we saw that the inserts, there were very limited possibilities to soft tissue balance, which meant we had quite a few dislocations. So that's also, we said, there need to be more inserts at different heights, so that after implantation of the components, you need to fine-tune the soft tissue balance by different polyethylene inserts. But that gradually came because of the observation we made early.
Before we go too far down the rabbit hole of design, because I really want to dig in on this and talk about the specifics, Didier, I'd love to bring you in at this point in time. At what point in this story do you enter into the equation? How did you initially become involved with the design team?
Yeah, so I started my career in 1996 in the Medinov company, the one that Anders just talked about, which was the company who was working with Professor Grammont and developing the initial Delta prosthesis. So I started to work on the reverse shoulder biomechanics in 96. So I followed roughly the story of the Delta from the beginning. Initially, the reverse shoulder designed by Professor Grammont was available only as a custom-made implant, and he started to use reverse shoulder implants in 1985. But when I arrived, it was already what we call the Delta 3.0 in Europe, which was the first available reverse shoulder in France mainly, launched in 91.
And up to this point, what had the predominant amount of your product design been in? What was your background prior to making the transition to the Delta 3?
So yeah, it's a good question. I'm a biomechanical engineer, mainly mechanical engineer. I didn't really have any medical background, so I really had to spend a lot of time discussing with surgeons, training myself on the anatomy of the shoulder joint. I had the chance, like Anders, to meet and to discuss with Professor Grammont, who really helped me for that. And I was really involved from the beginning since 96, working clearly specialized a little bit more on the shoulder joint.
Now, Didier, I want to get your engineering brain involved here. You're one of the first true engineers we've had on the podcast, and I know working with engineers that one of the strengths you guys have is you look at things from such a unique perspective. We've heard a brief description of Grammont's design. He had, a two-part humeral component with HA coating. He had a limited number of inserts. He had a Ekelund component that was a post and two non-locking screws, and then a screw-on sphere. When you think about that original design, what are some of the strengths and weaknesses you see within that design, knowing what you know about the shoulder?
Yeah, so as an engineer, I would say we always try to understand first what could be the advantages and what could be the drawbacks of every design parameter. And we had some background regarding the initial Delta, which was launched in 91. And then when I started to work with Anders Ekelund, we really created, I would say, a wish list. We knew exactly what were the problem to solve. And we also added a lot of other wishes, what we would like to improve. And we started from this kind of wish list from the initial Delta system. Because in the initial Delta system, it was not possible to combine any kind of humeral implant with any kind of glenoid implant. So it was something we wanted to work on that. There was not so much joint tensioning adjustment. There was only one pickup thickness, for example. We also wanted to add more modularity of the system by adding eccentricity on the glenoid components. And the key point, I would say, is always the glenoid design, because this is where all the forces from the joints are going through. And then the plan was really to reinforce the strength and the fixation of the glenoid, mainly by adding new locking screws designs, because we know from a mechanical aspect that locking screws are really much stronger compared to any kind of other standard screw.
I want to follow up you briefly about that. I mean, it sounds like that one of the key things that you were changing is making the reverse more adaptable to more anatomy, making it so you could do more mixing and matching to provide the surgeon with greater intraoperative flexibility. With that, it sounds like it comes to designing some modular connections. It sounds like some of the early problems were the modular connections. When you approach those modular connections as an engineer, what do you think of as like the optimal designs?
Yeah, it's a good point. So as Anders said that, for example, the initial connection between the glenosphere and the metaglen was a threaded connection. Of course, there are some weakness regarding that, because there is some potential unscrewing issues, and it happened in the past. So I would say right now in orthopedic, I would say the best connection is a taper connection, because we know that it provides a strong fixation, but it's also possible to disconnect a taper. So this is right now why on the hip, knee, even shoulder implants, we are really used to use a lot of taper connection, because it's something easy to connect, and there's still the possibility to unconnect it if something happens.
Andrews, maybe we could bring you back in at this point. We've talked about some of the predicate designs. We've talked about some of the merits of it from a biomechanical perspective. I'm curious about the early approval process in Sweden. Obviously, you implanted some of these. What was the process to get there?
In Sweden, it's a little bit different. At that time, we didn't have the CE marking and all that, the whole system. So at that time was quite easy. So when I brought in the second in 1995, the Grammont type, the first Delta 3 implant, there was really no approval process necessary. It was just the fact that the company had it, and the boss of the hospital said, "That's fine, go ahead." So it was quite easy at that time to get this implant and use it on patients. Today, of course, it's completely different with all the approval system, but it was quite easy at that time. I may add that And like Didier said, that the new connection on the Gleaner sphere with the center screw and the taper is quite good. But one of the problems we still see is that sometimes the surgeon, the Gleaner sphere is applied a little at an angle, which means that when you tighten the screw, it feels good, but you see in the post-op film sometimes that the Gleaner sphere is not fully seated. So it's still something that you have to be careful about and watch to make sure that it's straight on and goes to the taper is completely connected.
100%, and that still applies today. Truthfully, I'm fascinated by a world in which you can take modern technology, bring it to your patients, and start to implement immediately. As we've seen, there's always limitations when we pursue new, really pioneering technological advances. And so, obviously, it didn't sound like there was many barriers to implementation. But I'm curious if you encountered any resistance from the orthopedic community. You're introducing a non-anatomic arthroplasty. So was there any pushback due to a perceived sense of risk?
Well, I think that's why the Shoulder Society at our annual meeting decided that let's keep it on one place, which means the unit where I was working, and see what happens. And if we keep control and we watch it, and so if it fails, it will be not completely spread around the country. So we have it in one spot and very limited indication. The first year, I did 8 cases, and there were 8 revisions. So we really were selected the worst of the worst, because if it failed, we could at least say they were so bad, so they didn't really have a good life. Now, of course, we do hundreds and hundreds every year, but at that time, we were very, very careful, a slow start, observe potential complications before we increased the indication. And it was until 1998 when I switched from hemiarthroplasty for fractures to reverse, because I realized hemiarthroplasty is a bad operation, doesn't work. And from 1998, we switched in our unit as routinely to reverse for fracture. So we gradually increased indications from those revisions, cuff arthropathy, to fractures, to rheumatoids, and so on. So it's over time, it has been a widening of indications.
That is fascinating that in 1998, you're leading the charge with reverse for fracture. It really is incredible to hear that Stockholm was ground zero, as we say in the United States, ground zero for the implementation and unveiling of the reverse. What does market surveillance look like at that point in time? Were you seeing these patients back at a regular scheduled intervals? Were you obtaining routine X-rays? How do you monitor progress at that stage?
Yeah, I was really afraid. I must admit, I was afraid that it was going to fail at some point, like the older design, even though I felt this is a much better design. It makes sense. It's biomechanically good. And the fixation on the glenoid with the central patient at the bone metal interface, everything theoretically sounded good, but we were very afraid. So that's why we did some careful monitoring. So we of course, as we saw them back at about 2-3 months with an X-ray, and then we took annual X-rays. But then after a while, you realized nothing happened. They didn't loosen. And of course, we saw some dislocations. We saw some humeral loosening, but not much on the glenoid side. So we gradually decreased the follow-up. So nowadays, we see them at 3-4 months with an X-ray, and then we don't see them again. They just follow by the Swedish arthroplasty register 1, 2, 5, and 10 years by sending out a form.
One of the things you've mentioned is that original design was a post design. The Delta had a central post instead of a central screw, and that medialized design put the fixation at the bone implant junction. Now central screw designs have become very popular, and many systems have at least a central screw option, if not only a central screw. Didier, when you think back to that part, I mean, historically, even before that, there had been a couple of central screw designs. What do you think is the differences between those, and why was that a critical part of that early design, or maybe was not important? How do you think about that in retrospect now?
Yeah, so I would say first, if you have a glenoid design with screws which don't provide some compression, then a central screw, I would say, is something mandatory because we need to have some compression of the base plate. Today on the market, there are some systems who have some kind of locking screws which look like trauma screws. By that, I mean that this kind of trauma screws doesn't provide any compression of the base plate. Then you need to have a central screw to add some compression. I would say with the Delta system, we always add some compressive screws. Even with the new Delta Extend system, we have locking screws, but these locking screws provide compression. Then in this situation, I would say a central screw is not something mandatory because we already have some compression. Will it be important on our system to have a central screw? I would say it's only if you want to have a little bit more compression because you are using lateralized glenospheres, for example, or if you want to use a bone grafting technique, then a central screw as an option could be something interesting. Right now, we know that if you are not perfectly aligned with the glenoid bolt, most of the time the central screw get out of the bolt pretty quickly.
I also wanted to ask you, about the humerals. Oh, sorry, go ahead.
Yeah, I'm just going to add that I think, as Didier told, we had this meeting when we started to develop the Delta Extend, that we had a wish list. And I think I've always seen that if you change the design or change something, you first need to define the problem and then look for a solution. So having used now the Delta Extend for over 20 years in thousands of patients, glenoid loosening is non-existent. It's not a problem. So with the design of the Delta Extend, the loosening of a primary is basically zero. And we follow them. We've seen them now for 20 years. It doesn't loosen. So for me, why go to a central screw and change when you don't have a problem with loosening? So I agree completely with you. You have to look for the design. I think central screw has become a fashion that everybody has it now. All companies want to have it. But for me, it's not necessary because the fixation with the present design, with the central post, is good enough.
Let's go to the humeral side. One of the things that's fascinating is historically, we thought anatomic arthroplasty should be anatomic. You should make the humeral component look like a humerus. But now we're going to a non-anatomic arthroplasty. So I wanted to ask early on, what drove kind of considerations about what the humerus should look like, neck shaft angle? What were the consequences of that decision later on? So tell us, Didier, why 155? Like, why was that part of Grammont's design? Did he talk to you about that?
Yes, we had this discussion, and we still have this discussion with Anders and some other surgeon designers. He did several different designs. And as I said to you initially, and it was something possible at this stage, it was a custom-made implant. And then he did different neck shaft angle, and his conclusion was that smaller neck shaft angle were too much unstable. So it was clearly regarding the joint stability, and he defined that the 155 degree neck shaft angle was much more stable than the 145 degree and more than the 135 degree. So when we started and we did some tests with Anders too, we played with different neck shaft angle also during the development of the Delta, and we found exactly the same kind of result. As soon as we touch the neck shaft angle, as soon as we decrease it, then the joint is a little bit less stable compared to the 155 degree. This is why we kept this 155 degree in our Delta Extend design.
So Anders, did you place any implants in patients that were less than 155 in the early days, or was that just all cadaver or kind of more biomechanical testing?
And what we did was that we had trial inserts with different angles. They were asymmetrical. So at the time of surgery, I could try 155, 145, 135 by using different trial inserts in the definite implants. And then we had a measuring device that we measured the force necessary to dislocate the shoulder in vivo in the patient. And we recorded the force necessary for dislocation. And then we saw clearly how the force decreased when you went from 155 to 145 to 135 in the patient. And then, of course, we put in the 155 insert and closed the wound. So it was actually in vivo research in the patient.
But then tell us, there was this early problem with notching. Did you tell us what was the early experience with notching? Because that's, I think, since then really become understood as a consequence of 155.
Yeah, of course, we observed it on X-rays early. We saw two things. We saw this notching inferiorly, and also we saw some, and it actually was because we also saw osteophyte formation in the tricep insertion. But if you really look carefully, we saw this notching, and sometimes it could be quite significant. But you have to remember at that time, I had no idea really how to put it in. You put sometimes the metal in quite high, sometimes low. There was no guidelines. And we observed it, and most of it was stable. It comes a sclerotic line, and nothing happens after a couple of years. But in some cases, it progressed. But we didn't see loosening, even in severe grade 4, and it still is that they don't loosen in my experience. It's really rare. What we did see after 7-8 years, that they become unstable. Some of them, very few, but some, because of polyethylene wear. And then, of course, we had to go in and change the insert to a new one and to make them stable. But it was a concern, but not really creating a big clinical problem. But still, on the wish list, when we started 2002 to develop that back then, one of the wish lists on the wish list was, how can we decrease notching, maintaining Grammont principle? And that's why we came up with this, that you have to have a low placement inferior overhang, which was the most efficient way to decrease notching. And that's why the eccentric glenosphere was developed to make sure that the surgeon could achieve an inferior overhang at the time of surgery.
So just to make sure our listeners understand, I think what you're saying is that with notching, you get some wear of the rim of the polyethylene, and that leads to loss of containment, and then the shoulder can dislocate through that defect in the rim. And then, but one of the consequences of that decision to create inferior overhang is more distalization. So, I think there's now a lot of research into that. Do you feel that there are biomechanical consequences to distalization?
That there are some risks. One is that you can overstretch the deltoid muscle, which may have a detrimental effect. And also the cosmetic contour, it's really changed. And it may, even though it may not be proven yet, I think there's a risk if you distalize too much, there may be increased risk for acromial fracture, even that it has not been proven, but from just a theoretical way, I would be afraid of that. So there are some drawbacks, but I think if you have an overhang of 4 or 5 millimeter maximum, I don't think it's a big risk to do that.
I can even add something regarding this point, if I may. So we did a lot of studies with funders analyzing all the different parameters of a reverse shoulder and which one is the most efficient to decrease the scapular notching. And it was our conclusion that it's a low placement and creating an inferior overhang of the glenosphere. This is why we have eccentric glenosphere. Regarding the 155 degree, yes, it creates more distalization compared to a smaller neck shaft angle. But this is the most stable construct for and leading to a better joint stability. But this deltoid overstretching is compensated by the fact that we have an inlay design. So then by having an inlay design, we decrease this overstretching of the deltoid compared to onlay design. And this is something which is pretty important.
That's fascinating. With the degree of distalization, there wasn't more concerns or exposure to acromial stress injuries. You know, so much of our discussion in the current era is around kind of modulating the discussion between acromial stress, you know, deltoid tensioning, and then stability and range of motion. So I think it's fascinating to hear how a lot of this foundational knowledge really was launched in our field.
But I would say, yeah, today, clearly, we know that only design leads to more scapular fracture. I think there is plenty of published paper regarding that. And this is why we wanted to keep an inlay design for the delta system.
When did it make the jump then outside of Stockholm? When did things start to expand and it to go to additional centers? And then separately, tell us about the jump to the United States. Didier, you want to discuss, or Anders?
Yeah. So the jump was in 2004 with the early Delta design. So this design was named Delta 3.2 in Europe, and it's named Delta CTA on the US side. And we started the registration of this Delta 3.2 on the United States in 2004. We submitted this product to the FDA. We did a lot of mechanical tests to prove the safety of this system, and we already had a lot of clinical data regarding the Delta because it was used in Europe at least 10 years before.
Yeah, and I think in Sweden, it started, it took a couple of years, then a few shoulder surgeons became very interested when they saw the promising results. So I did some traveling to a couple other centers, and it was funny because I took all the instruments in a big box and took the train. And then we did some cases at some other centers. And then a few more years later, it started to spread more. But it was a quite slow spread to the different shoulder units in Sweden.
So my understanding is there's a gap. There's a period of time where reverse is becoming very popular or becoming more popular in Europe. And it's not yet approved in the United States until, as was mentioned, 2004. What does the in-between period look like, Anders? Are you going to meetings and having Americans get up and saying that you're crazy? Are there Americans traveling to Europe to get reverses? Pascabolo told me he had several patients who did so. And then maybe, you know, what does that period look like? Could you have memories of that period?
Well, yes. Well, I presented my first, I think, like 8 revisions at the CESIC meeting in Salzburg. And then I was invited to GMS meeting in the shoulder meeting in San Diego. And I presented some data on the early deltas. And so traveling to different meetings. And then quite soon I started a learning center in our unit where we invited international surgeons to come, and I did some live surgeries and lectures to show the technique at that time, which was different from today, but the knowledge we had. So that made it spread, or at least contribute to the spreading of the technique. But that's the way I try to get the information out.
I wanted to follow up, on something specific to that period. You mentioned at the very beginning when you did your first cases with Paul Grammont that he did them through an acromial osteotomy. Now, I think maybe a more modern variation of that would be the anterior superior approach, which I know is an approach that you still utilize. Were you teaching that approach in those early cases, or were you doing a delta pectoral approach?
No, in the beginning, I did all my cases through the anterior superior approach. I never used the Grammont type acromion or the acromion osteotomy. I actually did the anterior superior approach for my case at that time. Revision cases, I did delta pec because they had the delta pectoral approach. Scars, I used that, but otherwise, I basically did 90% of my cases with the anterior superior fracture, everything through the anterior superior approach. Today, I do the majority through the delta pectoral approach.
And then, why did you switch? What were the advantages or disadvantages of anterior superior? I mean, that's not a common approach here in the United States, but there are. Like I watched Evan Flato do one that he said he learned in Europe, and I think there are other shoulder surgeons here that have occasionally used it. What are the pluses and minuses of that approach?
That's a very good question. I think for four-part fracture, it's still a very nice approach. You get straight on, you get a shot on the glenoid, you can see the tuberosities. The drawback that I saw was that with that approach, with the retractors in, even in a small incision, there was a tendency for some atrophy of a little bit of the anterior part of the deltoid, which was anterior of the small incision. And I think that maybe it became torn or maybe it was affected by the retractor you had. So there was like a lack of deltoid contour on part of the anterior superior part of the deltoid. And that made me part of the thing that I switched. And also in some of the very stiff shoulder, it was very difficult to do complete release with that anterior superior approach. And that's why I gradually started to do, and also I did big bone grafts, which we started to use early. It also was very difficult through this anterior superior approach. And also they have a tendency for superior tilt of the metaglene because it was tight. So that's why I gradually switched to do more delta pec, because I thought this is more versatile. I could do much more. I can do releases. I can do bone grafts. I can, basically do everything through that approach.
So Didier, you mentioned the Delta 3.2, and we know that there's been a lot of changes to reverse total shoulder design since the Delta. Which of these do you think has been most impactful from a design perspective?
I would say clearly it's all about the glenoid. I would say it's always the same kind of discussion. What was really much more impactful in your system was clearly the fact that we understood that the creating an inferior overhang is the most efficient parameter to prevent notching. And then in order to create this inferior overhang, we had to design a smaller base plate in order to position the base plate as low as possible. We also increase a little bit the glenosphere sizes. This is why on the Delta system right now, we only have a 38 one. We are not in favor to use a smaller one because it will create less inferior overhang. And also the addition of the eccentricity on the glenosphere, again, just to increase the inferior overhang of the glenosphere. So for us, it's clearly the inferior overhang of the glenosphere, which is the most important parameter in the system.
And Anders, tell me about your relationship with the early adopters on the American side. Who are the individuals you are working most closely with in a constructive way?
Yeah. Well, I think that you met some doctors at the meetings, and of course, DMS, we had a lot of discussion. Charles Rockwood, he came over to Stockholm because he said, this doesn't work. This is, bullshit, never worked before. And he came to see, and we had a lot of discussion. And I don't know if I convinced him, but he hesitated. So we had a lot of discussion. Rick Madsen, we had also some discussion. I went to see him in Seattle. And so I would say Rockwood and Rick Madsen was two primary shoulder arthroplasty guys. that I spoke to at that time.
And just to add something to what Anders said, Charlie Rockwood was not convinced by the reverse shoulder biomechanic, and he was calling the delta the tool of the devil.
Yeah, and also, of course, Mark Frankel. Mark Frankel and I had an early discussion, lots of discussions early, and he was very enthusiastic. He was the most enthusiastic about this whole thing. We had great discussions at that time.
Certainly, I think that no one who's met Mark Frankel can describe him as anything less than enthusiastic about reverse total arthroplasty. Certainly, I mean, his design is very different, and he's told the story of his design on our podcast, which is fascinating. One of the things that I think is really interesting talking to him is that he was trying to figure out how to make the arthroplasty more anatomic, and we've heard a lot about how it's a non-anatomic arthroplasty and how to maximize that design. What are your thoughts, Anders, on this kind of idea of the anatomic reverse? I mean, how does that when you think back over all the history of the early revisions you did, Grammont's design, the changes that have occurred since, how does that sit with you? I've never quite known what to think about it. I think it's an interesting idea, but I don't know what to think.
Yeah, I agree. I think it's fascinating. I mean, discussing with his enormous knowledge and thinking and concept is great discussion. I personally I'm not convinced. I think this is a non-anatomical concept and based on the Grammont principle, which I truly believe in. And I think when you start going with the central rotation more laterally, mimicking the anatomical shoulder, I think we are introducing risks of failures like we saw in the past. And you will see more acromial fracture and you'll see more venous loosening compared to the classic Grammont design. So I'm not convinced. For me, my goal is not to see it as creating an anatomical reverse. I think there are two different concepts, and I think we need to continue to work to optimize the Grammont principle, but maintain those principles, not going lateral with a central rotation. That's my personal view.
Yeah, clearly, there is a trend to design a more anatomical reverse system, but clearly the basic concept of a reverse, this concept works because it's non-anatomic. So designing a more anatomic reverse is moving a little bit far away from the initial reverse concept, and we are not really sure about the potential advantages.
I think it's a fascinating discussion, and I think that it's important that there's people on both sides, and I don't know what will happen, but I do think that it's great that we have so many smart people that are working so hard on both sides of it. Now, you've one of the things that we've mentioned a little bit is acromial stress fractures, and it sounds like for you it was an inlay design. There's, I think, evidence on both sides as to whether inlay or onlay even matters, and the challenge with that, of course, is that inlay and onlay they have to do with how the implant is placed, right? So you can have an onlay component that is more inset relative to the humerus that has a pivot point that is more in an inlay place. You can have an inlay design that is placed more proud relative to the humerus that could have more of an onlay pivot point. I wanted to ask a little bit about how you created the sizing for the original implant. So when you think back to Delta, how did you figure out how big does the bowl need to be? Did you do a lot of research into the anatomy of the humerus and the various sizes of the humerus to get it to actually inlay? Tell us a little bit about that process, Didier.
Yes, so of course we had a very popular implant on the US market, which we call the global shoulder and then global advantage. And then we had a lot of data regarding the sizes of the different heads which were used. So we really designed our humeral component by using this big clinical data in order to match the implant size to the patient. So we clearly use that. Right now, we also added a new feature in this design, which is the possibility to have a posterior offset of the reverse epiphysis component. This is something which is needed mainly when you position the humeral component in a non-anatomical retroversion. And then this is why we added this kind of posterior offset option based again on the clinical data we had before in order to define how much posterior offset we need related to the size of the patient.
May I add to Didier, one of the problems we observed was that with the traditional preparation, if we wanted to put the reverse humeral component in less retroversion, there was a tendency to ream away part of the lesser tuberosity and the subscap insertion, and that's why we needed some offset built in order to maintain the cortical rim of the resection area when you introduce the humor. So I think that was really a step forward to maintain good bone stock proximally.
Well, look, this has been just a tour de force in the early design of the reverse, it's just phenomenally fascinating to hear your stories about those early designs, your interactions with Paul Grammont. This is about all the time we have for this episode. I want to thank both of you for taking the time with us today. I can assure you we're always made better through collaboration with our interdisciplinary teams, and our patients will reap the benefits. So I think all of our listeners will find, your insights, Didier, as an engineer, and your insights and stories, Anders, about your experience throughout many years with the reverse, really helpful. So from the bottom of our hearts, thank you for the time you've taken and for all the passion you've poured into our field. So for all Chalmers listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we'll see you next time.